when I dived into psychedelic assisted therapy, that's when I started to really see and how I went through my own sort of a psychedelic journey. That's when I started to put things together. Okay, this is what I have not been receiving, or this is what has helped me, and just really started to see the suffering of my patients and what they needed at that time.
Three, two, one. Liftoff.
Welcome back to the Ketamine Startup Podcast. This is where we talk about how to build a ketamine therapy practice, industry insights, and what's shaping the future of psychedelic medicine. I'm Kim, and today I have the privilege of sharing a truly remarkable conversation with Inna Zelikman, a psychiatric mental health nurse practitioner who's been transforming lives through integrative mental health care for over 20 years. Inna brings a unique perspective to our field. She's MAP certified in MDMA therapy, works extensively in both ketamine and psilocybin spaces, and serves as Director of Integrative Mental Health at Recovery Without Walls. But what makes her story so compelling is her willingness to share how her own psychedelic healing journey years ago completely transformed how she provides patient care. This conversation goes deep into the intersection of personal healing and professional practice, the importance of individualized treatment over standardized protocols, and practical strategies for preparing complex patients for psychedelic experiences. But before we dive in, a quick disclaimer. This information shared in this episode is for educational purposes only and does not constitute medical or legal advice. Always consult with qualified professionals regarding treatment decisions and regulatory requirements specific to your practice and location. Now let's dive into this transformative conversation with Inna Zelikman.
This is your host, Dr. Samko, and it is such an honor to have Inna Zelikman on with us today. Thank you so much for joining us, and I'm really excited to talk to you about yourself, your background, your journey, and where you are heading towards. So to begin, Inna, please tell us a little bit about yourself and what you're currently up to these days.
Yeah, thank you so much, Sam. Appreciate having me on your podcast. And I look forward to sharing my story. So, I am currently an integrative mental health care nurse practitioner. And I've been practicing for over 20 years. I've treated patients with chronic mental health issues, chronic pain, addiction. I'm currently the director in Integrative Mental Health at Recovery Without Walls, and I do psychedelic consulting work with Oregon and retreat centers. I've completed MDMA training with MAPS. I've also certified in internal family system level 1, and I'm certified in the somatic intelligence training course for trauma therapy. I also have a background. I've done a lot of functional medicine and trained in nutritional medicine. So as you could see, I have a pretty broad spectrum, a background that has been really helpful to me in my current work.
That's amazing, Inna. It sounds like, as I hear about your background, you are really committed to lifelong learning. And I can just tell that your curiosity and your desire to learn more has, is clear by your experiences. So I'm curious, what drew you into this space, specifically, whether it's with the ketamine assisted psychotherapy, the psilocybin therapy? What was the passion or the interest that kind of sparked things for you?
Yeah, thank you. It's a wonderful question. And there's a number of factors, one of them being my own experiences with psychedelics and kind of what it did for me, and I'll speak to that. The other one is really learning from my own patients about them having a treatment experiences and the kind of outcomes that maybe weren't favorable, or patients just simply did not benefit from them. The two areas that I think are really good to talk about, particularly where the outcomes were more problematic, is I'd love to share more about my own views and experience of our conventional healthcare system. And then the other one is actually in terms of the psychedelic therapy, and it's particularly maybe in cases when people were not adequately assessed for readiness for psychedelic therapy, right? And that's more in regards to where they are on trajectory of care. And for those who may want to know a little more what that means, trajectory of care It's a step-by-step journey that takes people through the healthcare system, right, over time. That includes treatments, appointments, or any kind of support that they received managing their illness. Perhaps I want to take a deeper dive into what I see is the issues in our conventional healthcare system. It's been for over 20 years, right? I've been treating patients who have mental illness and addiction, and I just seen so many complicated and poor outcomes, just people coming out of standard care. As a matter of fact, most of my patients were actually diagnosed with treatment resistant, depression or anxiety or condition. And I just see this. People are going in and out of rehabs, right? If they have addictions, in and out of residential centers. And the amount of SSRIs and SSRI attempts that have been done. I mean, interesting thing, there's actually a very little substantial evidence that show that antidepressants actually even provide benefits, more larger than, placebo. And yet they're so overprescribed. I mean, we also see patients are taking medications that contribute to, essentially addiction dependence. We're talking about sleeping pills, right? Benzodiazepine medications, opiates, stimulants. Um, I want to just give a little bit of a history, kind of the beginning of the modern psychiatry to kind of help the audience sort of maybe have appreciation how we got to sort of prescribing these medications. It all started around 1950s. This is where the first antipsychotic medication was essentially invented. And this is where in the United States, where healthcare system experienced a paradigm shift. Now our healthcare system started to view mental illness as like this brain chemistry imbalance and calling it like a biological psychiatry. And this is the theory that really favored the idea that psychiatric medications are the cure to mental illness. And now we've got this medication-driven solution, right? And this trend has just continued, for decades ultimately, right? And prescribing patients these medications led to dependencies, right? We have this overdependent nation. What was supposed to be, as they call it, a promised treatment to solve our mental health care issues, now it turned into something that's called treatment resistant. It's unfortunately this medicalized approach really there's a little attention in that was paid to the circumstances, right, that led to the development of mental health conditions. I want to read maybe a quote from Gregory Bateson, who's an interesting anthropologist, and this is how he saw the cause of mental illness. He said, in quotes, "In the ecology of an individual's mental experience, which is an integral pattern of social relations, culture, and family, in which we're all move, not just the mind itself." So clearly, right, understanding personal journey and their ecosystem, it's a much more holistic approach to care. I mentioned something is called trajectory of care. And what's not always thought about, right? It's like when providers think about how to offer ketamine assisted therapy, how do we offer psychedelic assisted therapy? I think what's important to see and to know, where is the patient at, like in their treatment process, right? I mean, what I see all the time is people seek psychedelic therapy when they're just desperate, right? Like they want a quick turnaround because they hear from their family and friends how amazing this was and what a beautiful result there were. But what people do not often hear from these other people, from their significant others, is actually the circumstances that they were in and the support that they received, right? That actually helped them to get to the right outcomes.
I wanna go back a little bit if that's okay with you.
Yes.
And so for 20 years plus you've been in this area,
Mhm.
like, was there a moment even before that when you started down this personal trajectory where you're like, "Hey, I think there's some issues in the healthcare system. I think there's some things that don't align with me." Like, can you tell us about that time, or was there a time when you started going down kind of a more open-minded path?
I came into doing this type of work, right? Like my earlier 20s. So
Mhm.
that time I was sort of going through my teens and what's interesting is that even if I had my own issues that were not addressed, right? Or things that I weren't able to see at that time, after I worked in the system and after I got involved in the psychedelics, that actually started to open my eyes, right? And open my eyes as to kind of really seeing a broader picture. Because even sometimes when we're taking care of patients, we might see things, but we just don't put them together, right? They're just not so clear. That all of a sudden, when you feel like your own life is all together, you start to realize how much of my own trauma that has not been solved and why has it been happening. And I'll speak to like there's a entire path when I actually got into experience my own psychedelics. This was about 5 years ago. I was at existential crisis, right? And I was suffering, and I just did not feel for what I was going through that there was a solution. I just like it's interesting, even though I'm in this field, I felt like I just don't think therapy is just going to work for me. Like there's something much bigger and greater is happening, and I'm suffering, and I can't even pinpoint as to what it is, right? But you know, deep down, there's issues, and something more dramatic needs to happen. And when I dived into psychedelic assisted therapy, right, that's when I started to really see and how I went through my own sort of a psychedelic journey. I call it a hero journey. That's when I started to put things together. Okay, this is what I have not been receiving, or this is what has helped me, right? And just really started to see the suffering of my patients and what they needed at that time.
Yeah, I think that's really powerful because Carl Jung talks about this
Mhm.
wounded healer archetype. And in a way, people in this space, I make up that we actually have our own wounds. And by healing our own wounds, we're able to support clients and patients move forward in their journey. So if you feel comfortable with it, so tell us more. Like, I know it was 5 years ago, this existential crisis. So I'm curious because, a lot of times people see leaders in the field and they think, "Oh yeah, everything's perfect and they have it all their shit under control and there's nothing." So if you're open to it, like I'd love to hear, like tell us what happened 5 years ago and like was there
Sure.
a pivotal moment if you feel comfortable with sharing?
Sure. Yeah, that's actually kind of an interesting thing. So until 5 years ago, on the outside, in a way, I had a great job, right? I was a mom. I had two kids that were growing up. I was married, and I lived in the community and sort of did like what everybody else did. And it was I would call it like a perfect family portrait, right? On
The white
one
you did you have a white picket fence?
yeah, yeah, like, sort of something like that, right? Like this
Okay.
beautiful little neighborhood here in, Marin County, like everything was just great.
Mhm.
Actually wasn't. Until and I think it's interesting, you probably will hear that a lot of that coincided with COVID. What COVID did or did not do, but it somehow put me in the place where all of a sudden, I am like, whatever was unaddressed just started to resurface, including the fact that I was so unhappy in my own marriage. You know, there is reasons why it takes so long to get out of marriages, right? And it's not always just because of complications, kids, and so on and forth. There's some for me, it was actually interpersonal issues and some childhood trauma that I just felt like just kept haunting me and preventing me to really take a leap and to leave, right, the marriage and create my own identity and really sort of make a move forward. And when I started doing the psychedelic work, right, I all of a sudden opened my eyes. So the feeling I had, like I had so much, and yet I had so little inside. It was so non-congruent, like to the point that I felt my mind was in the most negative place that I've ever found it to be. And I just couldn't, you know what I mean? And what's the hardest thing I think maybe other healthcare practitioners would experience as a patient, you just kinda, like, seek out healthcare. Sometimes I felt because I was holding so many people's lives, and I feel like I'm already in the position of responsibility, right, and authority, and I need to save others, and I just felt at that moment, I felt alone, and I was like, "How do I take care of myself? How do I help myself? What is it that I needed?" So I started to, in a way, curate my own healthcare. But psychedelics started showing me the way, and I tell you, this hero journey was, like, pretty wild. People just have this idea, they do the psychedelics, they see the reality, and all of a sudden, things are changing. Well, I tell you, it showed so much, but psychedelic therapy doesn't just reveal its resources and something beautiful and creates a catalyst, but it starts to dive into your shadows. And when it dives into your shadows, there is a pretty good chance that a person can actually experience a profound states of depression, right? Because there's a material that's coming out. if a person, right, like if I weren't held, if I did not know how to do this, I think it would have been a very dramatic path for me, right? But I knew how to reach out, but there was a still sense that I don't know if someone really knows what is it exactly that I need, right? And I had a beautiful supportive mentors, but deep down I said there's something people don't know. There's something is not quite being seen. And I can only see things a few months into the journey, right? I had these moments, I'd wake up and I'm like, "Oh my god, is this the reality? Oh no, I think that was the reality or this is the reality." And it was just such a wild ride. But what was interesting, right, is that my transformative experiences and my informative experiences were pretty crucial to kind of really help me to see how is it that I need to take care of patients? What is it that I need to do this? And I started to see that we don't yet know, okay? As much as we talked about psychedelic work, right? As much as there is some studies are done, okay, these are studies, they're not real cases. We still yet only touching the beginning as to what is it the person needs to really get through this. And this is a long path. It's not a quick fix. People are just, even in my practice, people are like, oh, we'll just do one ketamine therapy. This is going to be the end. No, no, no. This is why it should never be at the very beginning. People have to be in it, already in the process, and you have to keep them going. You have to keep people trust in the process, that creating the bond and but breathing, you'll look at every aspect of somebody's care, right? Not just like, oh, what's happening in the mental psyche? Okay, well, what's going on in the parallel life? And it was a really, really, really painful, actually, beautiful and painful 3 years. But when I completed the journey, I studied something. I said, I went from hero's journey to heroine's journey. And the difference for me, heroes goes within. Heroine starts to wonder what the world needs.
Wow. That's really fascinating. And I'm really glad you brought up the concept of hero's journey because Joseph Campbell,
Mhm.
who originated that concept, resonates with me. And one of the things that Joseph Campbell talks about, it's one of my favorite quotes, is follow your bliss.
Yes.
And I'm sure you've
Yes.
heard of that.
Mhm.
Um, so I would love to hear. So you had kind of this existential, or not kind of, you had this existential crisis. You worked through it. You sought out kind of alternative, non-traditional methods
Mhm.
of self-healing. How did those experiences do you feel? Because it sounds like they were both positive, neutral, negative sometimes. How do you think those experiences has impacted the way you provide care for your patients now?
Yes, yes, it's a great question. I believe in something that's called a holistic approach to care, right?
Mm,
Holistic is not something that is just involves psychedelics, where we use psychedelic medicine as an important tool. And if it's brought in place at the right time, will do exactly what it needs to do. I mean, we know in general, right, the psychedelics are great for treatment of major depression, anxiety disorders, substance use disorders. But they're also really particularly helpful, right? When people have complex trauma, right? When they're stuck in the loop of old thinking behaviors and it just in the trauma that just remains unaddressed, right? And psychedelics do have a way of taking people really into these spaces, into consciousness, and patients are able to remain in the regulated state so they can process the trauma. So when a patient comes to my care, right? First, what I do is I actually do a very comprehensive assessment. And what is comprehensive assessment? It includes, records review, right? We're looking at about past treatments, medications, tried and failed. I also tend to talk to any pertinent or important specialists that are either involved in the patient care now or in the past, because they are an important players and important parties. And they also will be a support if I create an alliance as to how I'm going to navigate the cases. I also spend a lot of time really learning the patient's life narrative, any kind of trauma, any history of attachment issues, right? Understand their families and dynamics. And particularly, I pay attention, what is their environment? What is the support system? Okay. The key to comprehensive assessment is to really, for me to identify a specific ingredients, right, that I needed to create a treatment plan and execute it so I can execute it in the right sequence. So, for instance, we're talking about what happens right after the assessment. There's a phase. There's certain patients that need stabilization. Maybe they need medication adjustments. Patients who may be deep in addiction, they may need to go to rehabilitation centers. Sometimes they need walls, okay? But then we create a very strong aftercare program that has a lot of safeguards in place. We connect them to psychotherapists. We start to address any medical issues that also can impact the psychological issues or even ability in engage in psychotherapeutic process and later on to even do any kind of psychedelic therapy. Once we have that addressed, once I got to know the family and the family dynamics and the environment, and I assess that it's stable, this is now the right time. That's when I start presenting or offering them opportunity or exploring the idea of doing ketamine assisted therapy. I often even feel that talking to if there's cases where I do my own therapy and I do ketamine assisted therapy, in certain cases where we need a lot more people involved, I might work with additional therapists or providers, right, who have an opinion and may want to be involved in care, even decision making around ketamine assisted therapy. Once that's set, the next phase, this is where we start talking about, well, what does ketamine therapy do? Like, what is the person's expectations? I tell you, so many times people will say, I just don't want to be depressed, right? I think it's going to cure me. Or they might just feel like this is my last resort. We have to be really careful with that and really sort of help them understand that it's not just the final outcome, the relief or removal of the symptom. It's sort of the process. Then I also look, right, as I get to know how motivated they are to do the work once they do the ketamine assisted therapy. As you know, there's so much emerges from that. And then we really work on the intentions because intentions are so crucial as to what it will affect, what will happen in the psychedelic therapy, what would happen in that space, what may come out, how we're going to work with this, right? Which would be the very last part. This is the integration. And in integration, we just continue revising the treatment plan. We continue talking about the process. You know, one interesting thing, there's a really common way that a lot of clinics or practices may operate sort of on protocols, meaning ketamine will be given to everyone twice a week or once a week for so many weeks and then it changes, right? Well, that's a kind of a cookie cutter approach. It's not very individualist. Yes, it's based on, certain literature and research, and there's a lot of studies were done in IV infusion of ketamine twice a week. But I think we're missing something at that moment. I believe in something that's called organic process. You do one ketamine assisted therapy at a time. Okay. That could be twice a week. That could be once a week. That could be every other week. And it's whatever amount of session the patient needs. But there's so much can emerge from that. And there needs to be room to process. Or if you've got somebody who's so depressed and they've got to like get a little bit more ketamine, just the medicine itself to kind of energize them and to deepen them or drop them in, then maybe it's something we would do more frequently. And, yeah, and then just, of course, observe it's it happen, in their environment around that time.
So, you mentioned ketamine assisted psychotherapy,
Mhm.
and then there's ketamine infusion therapy. And then, with the scientific literature, some studies are showing 3 times a week, other studies are showing twice a week, some other smaller studies are showing once a week. And I'm hearing from you that your approach is actually not necessarily following those protocols per se, but more of an organic approach.
Right,
So
intuitively driven. Mhm.
intuitively driven. So tell us more about that organic, intuitively driven approach, like how, because it sounds like every person is almost going to get their own scheduling based upon that
Mhm.
individual's needs.
Mhm.
So tell us more about, how do you decide what the frequency is? Because it sounds like it's less protocol driven and more individual focused.
Right. And again, of course, I pay respect to how the patients historically have responded, right, to ketamine assisted therapy. So at some point, you may know this person may need a little bit more frequent sessions, or a certain person you just don't know. What if it's not even their medicine? Or what if something arises that's so complicated and there's some trauma or a story or memory comes up that they've forgotten it. And, like, what happens to them afterwards, right? How are they received at home? So that really influences how big the session, how much came up. And also, is this person being able to integrate this, right? Did it kinda go over their head? Were they willing? Are they motivated to do this? And if this is somebody who is, and in the cases, let's say when I do the ketamine assisted therapy, maybe we touched upon something, but we haven't, like, walked through the door, right? It would be a disservice to wait another 2, 3 weeks, right? A person is ready. There's something being opened. It's like breaking the ice that you wanna repeat it a little bit more frequently. So consistent dialogue from the provider and the patient.
Yeah.
And that's how we determine the frequency. And yes, there's, in ketamine, we know the reason why it's done so frequently, and the studies are using it frequently because of the critical period, right? The time window. For some patients, it's, 24 hours up to 5, 7 days. But for some people, the critical window will close, but there's some information that's there that they're
Yeah.
still processing, right? And that needs to be respected.
Yeah, and I love what you're doing, Ina, because you're not only working in the ketamine space, but you're actually working with in Oregon and with the psilocybin. So tell us, I'd love to hear what are you doing in the psilocybin space in these other states besides California?
Currently, what I do in this Oregon space is I do something that's called psychedelic consulting work. But I wanna share a really cool story, actually, that, of my own psilocybin experience, where it really helped me to crystallize my intention to really bring my knowledge, right, beyond the private practice into this wider arena, supporting, this ethical, well-prepared, and effective psychedelic facilitation. This was about 2 years ago. During that session, it was a facilitated session, I felt like I had this vision of being welcomed by these multiple generations of great-great-grandmothers, and I have a history of great-grandmother who was a healer, FYI. And it felt like it was an initiation into a lineage of female healers, the kind of initiation where I started to feel deeply connected. There was a message. Now you see what we see, right? Sort of this ability to step outside of mainstream and being able to sort of observe what's needed for me or others. Then there was this image, right? I perceived this vast earthy ring of fire. It was spinning with this increasing momentum, right? And it's like this radiant magnetic force. And it was a powerful force, right? It was alive, it was creative. And again, there was another message in it. And the force felt like a life force, which is intelligence that's been created in this universe. And the message was, we don't really need to reinvent the wheel. Like, we already have something. We've got this source. All we need to do is access it. And my role, right, it was a reveal to me. My role was to bring people to the source. But the interesting thing, not every psychedelic experience can be integrated the next day, right? Sometimes things a little while it takes a little time. I remember, I came back into my normal life and like, "Whoa, what was that all about?" Like, I'm not going to work and I'm not doing this. This is kind of wild. But in the meantime, right, it's still in our subconscious. So there are certain steps that I've taken since then, and at some point, it all kind of made sense. What made sense to me, what was the source? I realized that the source was the psychedelic medicine. And what does that mean for me to bring people to the source? It meant that I needed to support others and access these experience with care, with responsibility, with intention, right? So what I ended up doing, I currently have a license in California, but I ended up getting a nurse practitioner license in Oregon, and I started the private consulting practice where I would advise patients, healthcare providers, and service centers in how to properly refer the patients and how to assist them through this care. Something interesting because of my expertise, I got connected and I was invited by Healing Advocacy Fund to participate in a webinar. It's actually the webinar was on the topic as to how to refer patients to psilocybin centers. Just a little bit what advocacy fund is. It's a healing advocacy fund. It supports Oregon psilocybin services, but it also recently extended their services to other states that adopt the self-regulated model for psychedelic healing. So the psychedelics services, psilocybin services, are being enrolled in Colorado, and another year or two, it will also start happening in New Mexico.
Yeah, and you know what's interesting is I know that Oregon, Colorado have legalized and allowed medical professionals to use it. And this is just kind of what I've been hearing on it's on the news or whatever is there's like psilocybin centers in Oregon that have closed, right? I don't know if you've heard about this and then other places. And I'm assuming it's because of regulatory fees or licensing fees. And this is really interesting because there's like, there's critics who push back and say, hey, psilocybin, for example, is literally grows from the ground. It probably grows in Oregon and, in the Pacific Northwest and in Northern California. So they're saying, hey, look, this fungus is growing from the ground. And, why are you charging me, this is a patient, $3,000, $5,000 for something that grows from the ground? And this is actually something we get about ketamine too where people say, "Hey, ketamine, I can get it in TJ, Tijuana for, $5 a vial or whatever. So why am I being charged, $800, $500, $1,000?" So what are your thoughts on, you know, like how would you respond to that or what's your opinion on this?
Sure. Well, I'll respond in two ways. One is I'll respond as to why care does cost so much money. And two, I wish this care was also covered by health insurance companies, right? This is what we need to move towards. Probably part of the influence why psilocybin centers are closing, not only because licensing and keeping the psilocybin centers are so expensive, but also because it's such an expensive care to even, they need to keep enough patients going, right? Coming through psilocybin centers. As a matter of fact, in my consulting, what I've noticed, a large percent of patients are not even from Oregon. So I'm consulting like all over the world. I mean, we're talking about people from other countries that travel and do psilocybin, right? Of course, they're also traveling to different retreat centers. And you're right. So they're not paying $3,000 for psilocybin. That's like $100, right? Ketamine is $100. It's really cheap. What they're paying is, because it takes so much money, right, to run the psilocybin centers. Therapists have to sit with the patients for 6, 7, 8 hours, but also there's like 3 preparation sessions, right? They're about an hour or 2 each. There's 2 or 3 integration sessions. So if you divide it in hours, a psilocybin center can span up to 12 to 15 hours in doing preparation, the journey, and integration.
Right.
So if you do the math, right, it really does come out sometimes like $150 to $200 an hour, and they pay fees. So they're actually not making money. That, believe it or not, these psilocybin services are not making even a lot of them that much
Yeah.
money.
Yeah, I know exactly what you mean. So this is where I think the confusion comes in because when we say, "Hey, it's the ketamine that's helping," or "It's the psilocybin that's helping." I say, "Yes, and it's the social support and environment,"
Yes.
right? The container. And I
Yes.
think that's a really crucial piece, whether that's the physician, the clinician, the NP, the PA, the psychotherapist, the psychologist, etcetera, like
Yes.
everyone involved, that's actually part of the set and setting. It's not just the molecule.
Mhm.
And that's what I've really realized during my practice over the past 8 years is the molecule is one piece of it, but
That's
it's
right.
actually the entire container
It's set and
that
setting, right? It's set and setting. And
s
setting is not just the room, right? We're talking about the full support system because it's like 2 people, right? Or even the same person takes psilocybin, the same dose, the same medicine, the same mushroom, right? At a totally different setting will have a complete in a different time, would completely have a different effect. Or it's just not gonna get integrated, right? There's no one to integrate that. We know that what psychedelics do to produce a state of neuroplasticity, but it's only 1, 2, 3, 4 weeks, right? So that state goes away. But what do you do with the knowledge? And also, what I've learned, even in my own journeys, not everything you see, you follow every trail. But certain things you might want to follow. You may wanna pay attention to that. And how do you pay attention? Like, somebody really needs to help to integrate that, or that becomes disjointed or just too much, overwhelming.
Hey, listeners, this is Kim, and I just want to acknowledge that you're here for a reason. Maybe you're stuck in a cycle of long shifts, feeling a little burnt out, and wondering if there's any other way to practice medicine, especially on your own terms. We've been there, and that's exactly why we created this free checklist. your step-by-step roadmap to starting a ketamine clinic without those costly mistakes. Grab your copy now at www.ketaminestartup.com/checklist. It's completely free because we want you to succeed, not struggle. And hey, if you're driving or mid-workout, don't sweat it. Just check out the show notes for the link when you're ready. And again, that's www.ketaminestartup.com/checklist. Now let's get back to the episode.
This is a question that I wanted to ask you earlier
Mhm,
because part of your intake process, it's very thorough, right?
mhm.
You're talking with the patients, you're talking with the family, you're assessing their environment. So for you, how do you decide when you say, you know what, actually, we're not going to be able to provide whether it's ketamine therapy or psilocybin, like, do you have personally screening criteria that you say, you know what, I don't think it's appropriate for that person?
Yeah, it's actually an excellent question because that is so much of part of my consulting work, right? That
Hmm.
I do in Oregon. So oftentimes, either patients or providers find me or psilocybin center refers because there is a confusion, or a patient might be on multiple medications, right? Maybe they have a complex medical history, complex psychiatric history, and they don't know, is this the right time? Is this appropriate for them? This is when it's such an important to have the right expert.
Mhm.
There's a lot of talk about, oh, it's about medications and which medications are contraindications or not with the psychedelic therapist. And I'm going to say it is such a small piece of whether a person is ready to do the psychedelic journey or not. So I have like what's called a street light criteria: green light, yellow light, red light. Okay,
I love it.
and
Okay.
I can sort of explain that, right? So when I provide consultations, first of all, they're very comprehensive. It's not about just what meds they're on, right? It's really the entire sort of history, what's tried, what's failed, what's happening now. Do they have a support system? And most importantly, are they in the regulated emotional state? If a person is so dysregulated when they show up to their psychedelic journey, they are they are likely to come out in a dysregulated state, whether it's that day, whether it's 2, 3 days from now.
Mhm.
So that's one of the criterias. Okay. By the way, psilocybin centers in Oregon, which is a little different than Colorado, they have their own specific criteria. So, for instance, people who are on lithium or have taken lithium in the past months cannot participate in psilocybin. Patients with active suicidal ideations cannot do this, and patients who have history of psychosis or actively psychotic cannot participate in psilocybin care. I don't think they have the same regulations as far as purely for the psilocybin centers in Colorado. However, there's only a few patients that are exactly in that category. I find mostly everybody's in the yellow zone. So when I do these consultations, what's important to me, so I never in the end, by the way, tell patients whether they should or should not go through psychedelic therapy. It is their decision. My role is to properly assess them, to provide them with literature research to support some claims or data, but to give them enough information so they can make the most informed decision. So that's on one level. I work with the psilocybin centers, right? After my assessments, I talk to them and I might say, I have concerns that this is a high risk patient. And I'll talk a little bit about that. And I will not advise that there's a likelihood of harm or adverse effect to happen. And I would not advise for this patient to participate in the care. And I would explain why. Okay. But I also would assess or share with the patient that, look, this is what I see is happening. Maybe these are the medications that you're taking, right? Or maybe you're actively drinking, and this is not a detox, okay? You may want to go to center. You may want to stabilize from alcohol. Also, if you speak to people who've been working in recovery, they know that psychedelics are not, yes, there are cases, people taking the psilocybin, they're taking ayahuasca, and they're good, okay? That's not the case for most people. They need a lot of support, right? And they also need to stabilize their brain chemistry. There's an interesting thing that's not known, I feel. When we're assessing medications, for instance, I like to use there's 2 categories. There's one category is, okay, medication interactions with psychedelics, okay. By the way, an interaction means they may diminish effect. It's not necessarily a fully adverse effect, it's just a diminished effect. That also may never happen just because there's studies around it. There's a lot of patients take these medications, they have a psilocybin journey, and everything is great, meaning it did not cause, or patients that might not have had a visual effects, but it didn't change their outcome, and they still experience, let's say, relief in depression. So, what this is a yellow zone, right? This is where I'd say, okay, well, you're maybe on a lot of type of medications that can limit your effectiveness. Okay. How soon do we really want to, how soon are you motivated to do the psychedelic journeys? Okay, what's the risk and what are the risk factors? Maybe you're somebody who could taper a little bit, or maybe it's somebody, it's not a good idea. You can go ahead and do the psilocybin work, even with all of these medications, but do work with your providers, right? On ultimately changing them. I mean, one way I look at psychedelics, if they can help to heal, maybe we can also heal the nation by helping them to get off these pharmaceuticals, and especially like SSRIs and SNRIs. So, but there's another category of medications. That's what people don't, I feel, don't know. And this is the lens I have. And I cannot tell you how many patients I've done consultations that were not aware that this was an issue. And I think it helps even facilitators and centers to really know this one fact. So there's a category of medications that will not interfere necessarily with the psilocybin journey, but the effects that they have on the brain, we're talking about sleeping pills, benzos, opiates. Can I tell you, Oregon, huge addiction to kratom, okay? You could still take psilocybin, okay? It's not a contraindication, but the drugs will take over at the end of the day. They will not be a positive outcome, even if it's a beautiful journey, because the brain needs to heal. So these people actually may need to address that first. I want to talk a lot about yellow zone because I'd say we'll find a lot of patients more in a yellow zone. Yellow zone is this. Look, you could go through the journey. However, there are a few things, number of things that may need to happen for not only the journey to be safe, but also to be effective. And I do it in two ways. One way, if this is a person who travels to Oregon or somehow is going to be in California and they can see me before I'm able to engage, do a therapy with them or prescribe something, then I might engage with the patient. And I've done this in cases where there is enough providers involved, okay, and the patient is motivated to share. By the way, oftentimes people don't even tell providers that they are actually doing these journeys. But if people are motivated, but I see there certain things need to happen, my assessment doesn't stop that consultation with that one session. People will come back, okay, and they've come back with their family members. I brought therapists into the sessions and I brought prescribers into the sessions, right? So I help them to navigate the system to get what they need to prepare to change what needs to change. Because if we do this, the integrations are going to be so much smoother. Then at this time, I will work with psilocybin centers. Let's say if it's somebody at risk, okay? But they're not a contraindication, they're just at a higher risk. Higher risk people just need safeguards. Then we'll talk about it. Okay, crisis. What could happen if a person may have emergency? Okay, what happens the next day? Let's say somebody did become dysregulated. Things can happen, okay? I mean, things happen in regular medical system. As long as we have a provider, as long as we have therapists that are readily available to manage these patients, then we can bring people who are even complex to psychedelic medicine.
I wanted to go back and just rewind. You said that there is one category of medication that a lot of providers and centers don't know. And just to clarify, what was that category or the thing that most people don't know about?
Yes, and that's what comes up a lot. So when patients are treatment resistant,
Mhm.
oftentimes these patients either on or have been on sleeping pills. We're talking about Lunesta, Ambien, that category. Okay. Benzodiazepines. Okay. Klonopin, that's the same category. Ativan. Now I'll just share a little bit what we do. Okay. How we address it, because it's kind of an interesting thing. So we rotate patients, and this is where I'll help them. I actually am speaking to somebody who's in Europe right now and bringing their psychiatrist and addiction specialist to help them to get off the sleeping pill. And what we do, we rotate them to, let's say, a longer acting sedative like Librium or phenobarbital. And as long as we stabilize them, okay, and they're in a relatively okay dose, it's not a contraindication. They can do psilocybin. All they have to do is be stabilized. And when you change it to something else, you saturate receptors and you allow the brain to actually start healing. they probably will be 50% better just from that, you know? That they can sleep better. So we're setting up, a brain and a body to function. If you were to bring any from alternative treatments to psychedelics, all of a sudden, now the system is much more flexible, and it's set up to learn to self-regulate. In this state, when you do therapy, when you do psychedelic work, it becomes so much more effective. What that means, it's like the other treatments do not fail necessarily. It's what the person is taking and what's happening now is what creates either negative or just doesn't create any positive outcomes. And that the most common thing that's happening now, because people who are seeking psilocybin centers, they're not always seeking for self-exploration. They're desperate, or they're actively drinking. I've had actually a few of those cases, or using substances. And I'll say, let's say in cases there is somebody who came on kratom. I said, look, stabilize on buprenorphine. The minute you stabilize on buprenorphine, you are a prime candidate. There's research right now going on at Johns Hopkins of putting people, with the psilocybin and buprenorphine. Fabulous medicine, right? So we don't need psychedelic. I mean, ibogaine is a different story, right? We're not. This is its own category, but we're just talking about different psychedelics. Then the psychedelics doesn't have to detox you, right? Or we don't know what the opiate's going to do, right? As the psychedelics taking effect. So stabilizing that system, now the psychedelic can get into trauma or issues that are underlying the substance use. That's how psychedelics helps the substance use disorder. But they should not replace the appropriate, look, not all conventional healthcare is a problem. I mean, I work in conventional healthcare, I've done this, but it's the kind of conventional care. So people, when there are multiple meds, they can go from antidepressant to St. John's wort. You got to take them off and you got to give them something else in between to stabilize that system so they can let go of that, but not disrupt. The drugs have changed their brains for quite a long time. Something needs to unwind these brains. Something needs to heal his brain. That is so missed in a healthcare system. And now we've got the psychedelics, and it's great. But it's like, if we have these amazing things, but we don't use them in the right time in the right place, it's just nothing. There'll be no outcomes. And we see this. I mean, look, people do go through the centers. They're safe. Most people, actually, there's very few patients. The reason psilocybin centers, there are more of a social system, meaning the providers are not part of this. Oh, by the way, something really neat that's happened in Oregon and is already happening in Colorado. There is a health bill that's been passed allowing dual licensure, meaning 7 different boards that have licenses, including doctors, nurses, therapists, are now able to be facilitators and use the license. I mean, it's great, right? So, but it also frees providers. Okay, so why doesn't there's also there's reasons why there's no communication between retreat centers, right? Sort of psychedelic centers. There's layers, right? One is certainly providers are not really familiar with the psychedelics. Two, everyone is afraid to talk to the patients, and the patient's like, "I'm going to psychedelic center." Makes sense? So our system is preventing the dialogue. And what's really nice, when you legalize that, you're allowing now you harm reduction, really, more than that. Now providers can be participants and make sure their patients are ready for the psilocybin. But somebody has to train them, right? So I'm actually working on creating a training for providers, right? For psilocybin centers, as to how to recognize, how to deal with these complex situations. And I think if providers are educated and they're provided extra consultant and extra care, we're going to have more people in the right way entering psychedelic spaces.
I would love to hear about kind of 2 scenarios or
Yeah.
2 examples. One is maybe a patient you've worked with, whether,
Mhm.
actually, let's get specific to ketamine on one, like a really where they just had an amazing, just rock star, like OMG type of outcome. And then also just so that we could have a full picture, like the
Mhm.
opposite, like where you're like, "Oh man, this was a scary experience. I wish we hadn't done this." Or, where you're like, "Yeah, maybe this was not the most optimal. So can you tell us about like those two examples if any come up for you, Ina?
Yeah. Maybe I'll give one example that's related to ketamine assisted therapy that, oh my God, is amazing. And the other one would be more in the context of how we manage the patient who was high risk to put him through psilocybin centers. So I'll just briefly say a patient who, after working with this patient for a couple of years or even a little longer, right? This is somebody I've taken care of for 10 years at this point, right? This is a woman who was a chronic pain condition, who had a mental health history. She had a history of addictions, but she was stabilized. And in one level, she was having an okay life. But on the other level, every time there was this a pain flare or something would happen, there would be this cascade reaction of this emotional response, like the life was ending. And I was like, well, what is unaddressed here? And medications, and she was therapy resistant because it just felt like it was just getting her nowhere. Luckily, now the ketamine entered the picture, so we were able to start to do we were doing I think we did 2 or 3 ketamine sessions. And interesting, we actually did a few months apart, just the way it turned out. But what was uncovered, that there was something, an event that has happened to her that, first of all, how she ended up with the chronic pain, which was completely forgotten. But the body doesn't forget. That's the issue. The body doesn't forget. And then there was another traumatic event that came out in the second session where something was revealed to her, that's something that she's deeply regrets. And because she lives with this regret, in a way, it's like she compensates for that. She feels it's almost subconsciously that she's suffering is part of her life and she can't forgive, even though that she wasn't thinking about these events. But I tell you, over time, and so it's the changes are subtle, right? They're not just happening like overnight. A patient is a different person. But what I've noticed over a trajectory over a period of a year, there's a softening that happened. Now, when there's a pain flare, it would happen because it always goes away. A person did not feel so distressed. She did not feel so responsible. She felt like she could take time to heal and not just like, I need to keep going, because now I'm compensated for certain mistakes that I've done. I mean, it was so profound. Till this day, she feels, and we only did 2 or 3 ketamine sessions, like literally almost like 6 months or a year apart. For whatever reason, it just, maybe just she decided that was the range. But we brought it right at the exact time when something was happening and she needed to sort of dive into it. So this was one case. And I'll share a little bit about how we handled a very complicated case that was referred to me by Psilocybin Center. This was woman in her middle age, 40-something years old, who had a pretty severe OCD, was diagnosed a few years ago, has tried so many SSRIs, right? Like literally every SSRI. She tried tricyclics, she tried other medications, and basically has failed everything because she had pretty severe side effects and she could never, even if she get to the higher dose. So there's never benefit and there was a lot of side effects. So she stopped them. So then somehow somebody gave her a benzoyl-klonopin, right? And pretty soon she realized that she was building such a high tolerance within a few months. So she essentially self-withdrew, and then her anxiety was through the roof. So when I did the consultation, she actually was not on any medications at that point because just nothing was working. But she was showering and washing her body like 20 hours a day. She couldn't sleep. She was so dysregulated. And she was, kind of having a lot of suicidal thoughts like for a year. So red flag suicidal thoughts, again, for a year, not for a week, right? So we're not totally in acute suicidality. But she had a husband, which is really important, right? So there was some kind of a supportive factor. But I did not feel somebody who's so dysregulated, okay? At that point, there was no psychiatrist involved. She was out of state. There was a therapist who felt like he could only do so much, but there was a therapist in her hometown. And I just felt that this woman has to get regulated first. There has to be some kind of medication, something so she could sleep before she gets to psilocybin services. So what happened? She didn't get the help because nobody could see what I saw in her home state. So she actually ended up coming to California and she got treated recovery without walls. So we stabilized her. She stayed nearby. Her husband was involved the entire time. I spoke with a therapist in the other state to figure out if she were to be ready. So we decided if she stabilizes the next week or two, and if she's ready, then she can take herself to psilocybin service and get her psilocybin session. She stabilized. Obviously, OCD continued on, which is why she needed psilocybin. She went to Oregon. She had a couple of sessions, low dose, high dose. In the meantime, we really discussed her case with the psilocybin center because they kind of had to make sure, okay, what would happen if she reacted? How do we decide on the dose, right? It was what was important was a joint decision. So the studies right now for OCD are promising, but they're all short-lived. People are still dealing with the OCD symptoms. So even based on the studies, I realized these patients may need a lot of support. Maybe some will need medications, maybe some will need a lot of more engagement with OCD. But this patient was also high risk. I felt I don't know how well will psilocybin help her or not. She's tried so many things. I felt like I wanted her to give her a benefit or a chance to try the medicine. But I also knew there's a therapeutic window that's going to be only 2 to 3 weeks. So in a case like that, if she was regulated, so she comes back to her home state, and I wanted to make sure we get a psychiatrist there. So we're finding her a psychiatrist. I kept talking to her therapist. We put her in intensive outpatient program, right? So she can continue working through the progress. Look, there were things came up. We had to change medications. We had to do a little bit of like a mini post rescue, but she was safe. We safeguarded her all the way, right? So, and this is the case where no one would know can psilocybin help her or not. This is the case if she did not have the safeguard, there's no way I would have felt comfortable for a patient like this to just show up at psilocybin service. Number one, her thought was it's probably her last resort, right? So we're now going to have somebody high at risk if there's no follow up. If she comes back home and she still has OCD that severe, we don't know, right? This person is actually at risk for suicide. So I just wanted to illustrate the example that even complex cases where psychedelics may or may not work, we don't know, but we want to give them a chance. How we're going to handle that patient. So we're not putting her at more risk by doing something that we're hoping would help her.
Yeah. Yeah, and it kinda reminds me of, like, bowling, where you have the bumper guards for people who are just beginning, and you wanna make sure, like, "Yeah, you can throw the ball, but we wanna make sure all the safeguards are in place, so that, you don't end up in the gutter for the bowling ball." Now, I would love to hear because you're currently at Recovery Without Walls, and when I think about recovery, one of the groups that comes up for me is thinking about AA, so Alcoholics Anonymous, and I have some connections and friends who are part of the AA community, and what I'm getting from them, and I don't personally know a lot about AA, but I'm hoping you could, maybe you do, but with AA, it seems like there's an anti-psychedelic bent. I don't know if you've noticed that, where they're like, "Hey, that's another drug. You're just replacing alcohol with, ketamine or psilocybin or whatever it may be." What are your thoughts on that, if you can speak on that?
Yeah. Oh, it's excellent questions, actually. And I'm so glad you asked that question because in reality, we actually want more people in recovery to seek out psychedelic therapies. So we don't want a misconception that does exist. It's absolutely true in 12 steps. Historically, people couldn't even talk about it. They're on antidepressants, right? Because it was like replacing with the drug. Look, Bill W., he was given LSD. Okay, this is what started to become more known. Part of his journey was involved with psychedelics. He had to take antidepressants, right? So it's important, it's unfortunate that in recovery community, there's still these sort of strong opinions. There's actually an opinion against buprenorphine, okay? And yet there is a slow process. I just want to say, where does ketamine fall in that, right? So at least with psychedelics, there's enough studies, we have enough experience to know they're not addicting. Okay, you're not even taking them consistently, right? It's something I don't want to do psilocybin journeys daily. That's just a lot. Ketamine, it's an interesting category. Ketamine could be a double-edged sword. Okay, in the right place, in the right setting, it's a ketamine assisted therapy that actually can heal. In the wrong setting, we're now dealing with the emerging ketamine addiction, and we've treated that as well, and it's pretty actually complicated. And those questions in my patients actually come up a lot because in California, the only thing that's legal right now is ketamine, right? Besides cannabis is that I have to engage in dialogue because there's a fear, am I going to get addicted to it? So I have to have these conversations, and they often don't talk in the 12 steps. So I think over time, just like everything, right? hopefully that might be more relaxation that happens in that community. That there's another movement that's parallel to 12 steps, or not 12 steps, but parallel to AA. There is actually psychedelics in recovery, but they're slowly gaining momentum. And yeah, they're in different countries all over the place, right? This is the place where people are like, oh my God, I can actually talk about my psychedelic experiences. So that's beautiful to witness, right? So even though there's this bias exists, there is slowly a change in the shift that is happening in that community.
Thank you for sharing that, Ina. And our time is coming to a sunset. So I'm going to switch gears and ask you kind of some fun questions that you may or may not be prepared for, but take your time in responding. So the first question I have for you, it's kind of a deeper one, but what advice would you give your 17-year-old self?
God, if I could have done psychedelics back then, I still feel in some ways that might have changed my life, and it might have changed the trajectory of my life in a different way. On the other hand, maybe there's a reason we haven't, a person haven't done something when they haven't done something. Maybe they weren't ready. Maybe they needed to be where they needed to be, right? In so many ways, and have their own journey. So that's another interesting area around teenagers: who and when and how.
Wonderful. And I'm going to switch gears and ask you, let's say you could time transport and now you can talk to the 100-year-old version of Ina. And now, you're face to face with her and she has something to tell you. What advice do you think she would tell you today?
The advice would be trust that I am on the path and continue doing the global work that I've set out to do. That if I can look back, I feel changing people's life has become part of my mission, and it's become so important to me. And I want to be part of the greater system. And I just want to look back also and say, whatever happened to me needed to happen the way it needed to happen. I just need to stay the course and just keep living my authentic life and be true to what is it that I need in my life and how to find the right support and how to bring the right people. So that's what I would say.
And, after a long day at the clinic or at work or consulting, what's your go-to way to relax and de-stress?
Yeah, so I live on a beautiful houseboat, so I get a chance to go kayaking. So I'm always in the nature. I hike, and to me, that's the one way I always recharge.
That's awesome. You live in a houseboat? It
Yeah,
sounds
on a
like a lot of
houseboat.
fun.
I decided, okay, let's live life to its fullest,
That's
at
very
least
cool.
for a period of time, and just why not?
Okay, if you could have dinner with any historical figure, who would that person be, and what would you ask them?
Well, I guess I referenced earlier Gregory Bates, and plus, of course, I was
Mhm.
influenced by, an interesting sort of physician, right, I work with, who's been fascinated by this man so much. So it's like I grew up with this, and I'm actually reading his book or Tripping on Utopia. It's about Gregory Bateson and Margaret Mead and their story into sort of psychedelics. And I just really would like to talk more about this whole of like ecosystem in the healing and what he saw back then that some of us start to understand now.
And a lot of listeners may be curious to learn more about you or connect with you. So, what would be the best way for them to with you, whether that's, the social media, email, websites, etc.? Like, what's the best way for people to reach out and connect with you, Ina?
Sure. I ultimately want to give my email. It's called info@innazelikmanhealth.com. There are a couple of websites that they can find my work. One is called Recovery Without Walls. There's also another website that I've developed, part of the telemedicine. It's called Inna Zelikman Health. However, it's being redone to really illustrate more of the kind of work and passion that I'm doing currently. But yes, if they reach out through that, depends what they're looking. If they're looking for more personalized care, ketamine assisted therapy, something I do, I might bring them here in California. If they need a lot more psychedelic consulting and really supporting that, that I will find a different way that I will be supporting them. And I also, when I do the consulting work in psychedelics, some patients actually really love to continue maybe doing integrations with me or continue that process. Even though I'm not a therapist, I'm a psychiatric nurse practitioner, but many of us have grown to do therapy.
Yeah, thank you. And we'll be sure to put those below in the show notes. So if you're listening while you're working out or driving or commuting, you can just check the show notes for that contact information. And Ina, is there anything else important that we haven't talked about that you want to share? Any last thoughts, comments, complaints, anything for the audience?
I would just say that, of course, there's so much more to talk about, right? It's like I have such a desire to just dive into every little bit, but I feel like we've done a pretty good job, and I really appreciated having a chance to just share kind of my own story and the work I've done. And I hope that I've opened up audiences' minds and their hearts, and ability to see how beautiful and complicated the system is.
And I was reflecting upon the advice that your 100-year-old self would tell you. And yeah, I think you're doing it. I think you are a light for our community, and I'm so honored to be able to have spoken with you today and just learn more about you and kind of really the in-depth work with rigorous integrity, intuition that I see you doing. So it's been an honor talking with you, Ina. Thank you so much for your time, and I'm so glad that we're able to connect.
And thank you so much for having me on your podcast. Appreciate it.
Thanks for tuning in to another episode of the Ketamine Startup Podcast. If you found this episode's insights valuable, we'll really appreciate it if you would leave us a review on Apple Podcasts or Spotify. It helps other medical professionals discover these important conversations and grows our community of providers' commitment to transformative patient care. For complete show notes, Ina's contact information, and resources mentioned in today's episode, visit www.ketaminestartup.com/podcast. You'll also find links to Recovery Without Walls and information about her psychedelic consulting practice. And again, remember, this podcast is for educational purposes only and doesn't constitute medical or legal advice. The approaches discussed reflect individual provider experiences and should be evaluated with your own practice context and regulatory environment. Thanks for listening, and we'll see you in the next episode.